Glossopharyngeal nerve. So it is a mixed nerve carrying both the sensory and motor fibers. And solitary nucleus tractus solitarius. Okay. See here the course of it is supplying. In the pharynx, it is giving its supply, and it is coming out at the pontomedullary junction. Skull. You have seen through the jugular foramen passes the 9th, 10th, and 11th cranial nerve. So, accompanied by cranial nerve internal carotid artery. And then into the pharynx, and where it lies over the stylopharyngeus muscle and the middle pharyngeal constrictor muscle. It then passes under cover the palatine tonsil, mucous membrane, base of the tongue, and mucous gland of the mouth. The palatine tonsil, fossa, palatine fossa, and other fossas of the mouth, of the tongue, and mucous glands of the mouth. Now, what are the components of these three nerves? Mainly important for a short note, okay, or a part of a long question if it comes. So, so what are the components? Okay, or somatic visceral efferent, SVE, somatic visceral efferent. It supplies the stylopharyngeus muscle. Now, visceral motor component or general visceral efferent, parasympathetic innervation of the smooth muscle to the carotid gland. Okay. Next is visceral sensory component, that is general visceral afferent component, and this innervates the baroreceptors of the carotid sinus and the chemoreceptors of the carotid body. So these are the components of this nerve. This is a mixed compartment. It carries pain, temperature, and touch from the skin of the external ear, internal surface of the tympanic membrane, up tongue. Next is special sensory component, SA, that is somatic afferent, carries taste sensation from the posterior part of the. Their supplies are important. This is important branches of the glossopharyngeal nerve. Tympanic, the middle lesser petrosal nerve, which arises from this plexus and passes through the parotid gland. Next is carotid branch, which carries the sensory fibers, and now to stylopharyngeus, then pharyngeal branches, lingular branch, which supplies the posterior 1/3 of the tongue. So these are the important branches of the glossopharyngeal nerve. Next, what is the clinical aspect? If lesion occurs in this nerve, the general sensory component mediates the gag reflex. Okay, gag reflex means the tongue will be elevated and it will close the opening. And pharyngeal nerve clinically. Okay, gag reflex will be lost if the lesion occurs in the glossopharyngeal nerve. Nerve or spinal accessory nerve. So the accessory nerve is the radial nerve, and it has a purely somatic motor function. muscles are supplied by the cranium. This is the accessory nerve and this is the spinal root. This is of the spinal accessory nerve coming up. And this and trapezius forming the boundary of the two boundaries of the posterior triangle of the neck. So what are the nuclei? The spinal axis, lateral aspect of the anterior wall of the accessory extremity, and the cranial nucleus MBBS. Spinal portion arises typically from C1, C5 or C6. Superiorly, leaves the cranial portion which is in the skull, along the foramen. Outside, along the artery, the sternocleidomastoid muscle, the posterior muscles are supplied by spinal accessory nerve, sternocleidomastoid and trapezius. Along with the and 9th and 10th the extracranial of the accessory nerve is seen during dissection of posterior triangle. This important nerve was part of the posterior triangle, content of the posterior triangle, and traverses the triangle from sternocleidomastoid to of injury of this nerve because it is lying superficially if injury occurs in the posterior triangle. Okay, and there trapezius. Here also we can see this is the accessory nerve. There are two roots are joining, cranial root and spinal root. Coming out through the jugular foramen and the course hypoglossal nerve. Hypoglossal nerve is coming out from the medulla. See here, there is medulla in between the olive and the joint of the hypoglossal nerve coming out through the hypoglossal canal. Hypoglossal canal is occipital condyles. It is coming out through hypoglossal supplied much smaller and arises from the lateral aspect of the medulla oblongata and it leaves the cranium via the jugular foramen where it is briefly contacts the accessory nerve. And immediately after leaving the skull, the cranial part combines with the vagus nerve at the inferior ganglion of the vagus nerve and the fibers from the cranial part are then distributed through the vagus nerve. Okay. And for this station, the cranial part of accessory nerve is considered as a part of the along with the vagus nerve. Here you can see this is vagus nerve is also coming out through the jugular. Now, seeing of the accessory nerve is low due to any medical process in the posterior triangle. In particular, trauma to this nerve because jugular chain of lymph nodes. Okay, and this lymph nodes enlarge during biopsy. There is high chance of injury to the nerve, and cannulation of internal jugular to measure the pressure directly in the right atrium. shrugging of the shoulders, and damage to the muscles may also result in asymmetrical neckline. So, the final exercise side of nerve damage. Here, the muscle has been reduced. This is thinner than the heavy side, and here is the trapezius is also lost its volume. Okay. We have the cranial nerve or hypoglossal nerve. It is motor. So, spinal accessory nerve was only motor cranial nerve. Hypoglossal nerve is also only motor. Okay, but ninth cranial nerve, glossopharyngeal, was a mixed nerve. So, it is a mainly motor nerve, arises from the medulla at the junction of pyramid and olive. The rootlets are coming out, and nucleus is the hypoglossal nucleus. Okay. So, what are the functions of this nerve? It provides relaxation to the muscles of the tongue, except the palatoglossus muscle, which is the movement of the tongue. It is important for swallowing and articulation. It arises in the medulla and it leaves the skull to the glossal canal and descends in the which starts internal jugular vein and the vagus nerve. And it is joined in the upper part of C1 fibers. Here, this is the course of hypoglossal nerve. Okay. Fibers was joined. They are taking part in formation of the axon. In this is the ancestor fiber, and so it descends in the neck-like structures with the structures like the internal carotid artery, internal jugular vein, and vagus nerve. That is over the carotid sheath, and then passes forward on the side of the tongue. Here is the tongue passes forward on the side of the tongue, and is forced by C1 fibers. Cervicalis and meningeal branches supplying the nerve to the thyroid muscle, muscular branch to the muscles of the tongue, that is intrinsic muscles of the tongue, and now to the geniohyoid muscle. So these are the types of this nerve. See, there is the hypoglossal nerve. C1 fibers are joining with the nerve, passes forward on the side of the tongue and supplying the intrinsic muscles of the trunk. Terminal nerve, fifth cranial. So, what will be the clinical aspect? Hypoglossal nerve will cause deviation of the tongue to the affected side. Okay, because opposite side of tongue muscles or healthy side of the tongue muscles will push the tongue to the affected side. Okay, that's why hypoglossal nerve, the patient is asked to stick out the tongue and then deviate the tongue. It's noted that deviation is present by the weary and exhausted. So you have to determine the side on which side the tongue can is deviated if it during taking out the tongue. Okay, so it is 12 trillion. Now it has aquatic motor function, innervated intrinsic muscles of the tongue, right? Hypoglossal except intrinsic muscles of the tongue is important. Important short note. Okay, you prepare intrinsic muscles of the tongue. Now, yes, location is in the hypoglossal nucleus and distribution except the palatoglossus. Okay. So, brainstem located in front of the is medial to the dorsal nucleus of vagus and posterior to the medial longitudinal fasciculus. This is the location. Anterior to the medial longitudinal fasciculus. Medial line is olivary nuclear complex and comes out between the pyramid and olive at the pre-olivary sulcus and then passes laterally across the posterior cranial fossa within the backward space reach the cranium via the hypoglossal canal. Okay. Passing this is the section that place to internal jugular vein, internal artery nerve, then it will and through myofibroid muscle and enter the lingual region to supply of the tongue. To the posterior belly of the digastric function. It branch off to innervate the geniohyoid which elevates the hyoid bone. Okay, so this muscle innervated and here. The joint muscles of the branch containing C1 to supply this branch is corpora and cervical. Okay. A loop that cervical plexus and from cancer cervical to innervate muscle. All are infrahyoid muscles. Now, what are the functions? Hypoglossal. The vast majority of the muscles of the extrinsic muscles, intrinsic muscles. Extrinsic muscles are genioglossus, styloglossus, palatoglossus. Among these, this palatoglossus is by the glossal nerve and the hypoglossal nerve. Intrinsic muscles, medial longitudinal, and together these muscles are responsible for these intrinsic and extrinsic muscles are together helping in different muscles supplied by this nerve. This is a short note, very important short note. Okay. So you examine the hypoglossal nerve. Hypoglossal nerve is example and other movements such as the cheek and feeling for the pressure on the opposite side of the cheek may also be used. Okay, if your patient it will be dedicated to the affected side and it's less strength in pushing if the this nerve is paralyzed. Okay, so tongue muscles will also be paralyzed. The hypoglossal possible causes include the ANA malignancy and injuries. Patients will present with of tongue that is twitching of the isolated group of muscle affected side. Okay, tongue will be wasted if the hypoglossal nerve paralysis occurs, and fasciculations you will be seen on the affected side. Any queries regarding this topic? Okay, so you prepare the generally spinal accessory, and all these three nerves can come as a short note. You prepare as a short note, 5 marks question you prepare. You have to write all those things, its origin, course, nuclei, where it supplies and its components. Okay. Any queries? Components are important. Components are also asked in your viva during your Gantt fiber table or during any bones viscera table, brain viscera table. You may be asked the components or supply of these three nerves. Okay. No queries regarding these three nerves. Okay, that's
topic. And last, guys, please, this is going to be a 5 marks question for you. Straightforward. They will ask you this regarding this topic. This will be a direct 5 marks question for you. It is majorly asked because this is one of the topic that the students generally skip out while preparing for their examination. Okay. And the topic that we are going to discuss today is named as protein targeting or protein sorting. SORTING, sorting. Okay. And the other name provided to that, the most common name is protein targeting. Can anyone out here just discuss or can give a brief points or any discussion about what you understand by this term, protein targeting? Shall I write it on board? Anyone? Anyone with any ideology that what protein targeting is all about? Protein sorting. Can anyone just with this terminology? Last guy, that guy writing in that something book. Yes, last one. Yes, what is protein targeting? What do you understand by this term? I'm not asking you for any definition or anything. Terminology. I'm just asking you to explain me what does this term means. Please. Targeting. Target. What does targeting means? Anyone from the middle row? And why you people are sitting so far? God knows. That girl, side, writing something, anatomy, completing histology works. Yeah, what is targeting? That girl, right? Yeah. What is targeting? What do you understand by targeting? Hello? Anyone? This cannot happen here. Either you have to be interactive with me, otherwise I'll just read out the PPT and I'll go. My class is done. This cannot happen. You don't know what is the meaning of targeting. This cannot happen. Please, no need of standing up. Just be there, be at your place and answer. Sorry? Okay, fine. You have given the definition. That is okay. But I just wanted to know what you understand by this targeting. No one? Fine, you are right. I'm not saying you're wrong. To select a specific protein. Okay, fine. Anything else? Anything else? And what is the meaning of sorting out? What do you understand by sorting? Please, be loud. To organize something. Nice. Very good. Anything else? Anything else? Anyone? I'm just asking the meaning of these words. That's it. Yes. Sorry? To take up the? Nice. Very nice. Okay. Very good. Anything else? See, things are coming up slowly. Anyone? To address. Okay. To address specific enzymes. She has went to enzymes. Fine. Nice. All enzymes are protein except? Okay. Fine. Is that everything? Is that all? Whosoever has told whatever, you people are right. You are not wrong. To specifically distinct or allow certain protein that has to be set it for a different destination, or to provide a proper destination to a protein or an enzyme, that is called as targeting. We are targeting a specific protein to certain organelle or to certain membrane of the organelles. Okay. Now I have a chalk. Let us see. Page one. I have a chalk. I have a small piece of chalk. Okay. What is your name? Yes, what is your name? Shubhrudeep. Okay, Mr. XYZ. I cannot hear you. Fine. This chalk contains some information. Fine. It contains some information. I am targeting it to this guy. Fine. This is what targeting means. I have targeted that. My chalk is being targeted for that guy. Now there is one more piece of chalk. Let us say, what is your name? Mr. XYZ, tha na? ZYX. Fine. This is for you. Fine. So there is a differential targeting of specific proteins or specific elements of the cell that has to be provided to certain specific areas, or we can call it as organelles. This is called as targeting. Now what does sorting means? There are hundreds of proteins. There are many proteins inside the cell. Fine. Now which protein is going for certain area? Which protein is not going to that area? Which part of that chalk went to that guy? Which part of chalk went to that guy? This is called as differentiation, or this is called as sorting out. There are bunches of protein. Out of that, I take one protein for that destination. I took another protein for that another destination. That is called as sorting out. Is that clear? Now coming to my next query. Coming to my next query. All of you might have heard about different sort of proteins and enzymes inside the cell. Like we talk about nucleus enzymes. Let it be DNA polymerases, Pol1, Pol2, Pol3. You might have heard. There are different proteins inside the nucleus, of course. But do the nucleus produces protein? Do the nucleus produces protein? Yes or no? No way. The protein is synthesized in? The protein is synthesized in cytoplasm with the help of ribosomes. With the help of ribosomes. Is that clear? So all the proteins are getting synthesized in the cytoplasm. They are not synthesized anywhere else. There is an exception. We are studying biochemistry. It has got a chemistry part. So there will be exception. The exception is mitochondria. Because we know that mitochondria has got its own DNA. We call it as mitochondrial DNA. Right? So there are certain proteins which get synthesized or which are channeled out of mitochondria or inside the mitochondria to some extent. But if you talk about the 90% of the proteins and enzymes that get synthesized is majorly in the cytoplasm. Okay. Now, have you thought about this thing that these all organelles have got different proteins? Like nucleus has got RNA polymerases, DNA polymerases and all. Fine. The lysosomes has got acid hydrolases. They are enzymes. So basically they are protein. Fine. There are like different other organelles. There are perioxysomes are there. There are different other organelles which have got different sort of enzymes. But these all proteins or these all enzymes are prepared in the cytoplasm. So how they are taken into this different organelle? Have you ever thought that if this protein is getting synthesized in the cytoplasm, then how they are taken away to different organelles? Is my question valid or not? Anyone? Is my question valid? Yes or no? My question is not valid or valid? My question is valid? Do you think my question is valid? All of you? Yes, it is a valid question. Now to the answer, if you provide the answer to this valid question, the answer is nothing but protein targeting or protein sorting. Simple as it is. Is that clear? So the protein that is getting synthesized in the cytoplasm, later on if it is targeted, or the protein that is made in the cytoplasm is made for certain other kind of organelle, and we are channeling that protein to that specific organelle, that process is called as protein targeting, or we call that as protein sorting also. Yes or no? Is that clear? Is that clear? Now can anyone out of in this bunch of this class, can anyone just give me a definition of protein targeting in your language? I'm not asking in sort of bookish language or anything. No need of googling also. Anyone? I told you what is actually protein targeting. Anyone in your language? Yes, last girl. No need of standing up. You can just be comfortable within your place and just answer. In your language, in your words. Please go ahead. Anyone? She has given a good answer, but her medium is not acceptable inside the classroom. The medium of answer is not acceptable. Anyone can just, translate it into English. What she has said, again I'm saying in Hindi only. उन्होंने कहा है कि किसी भी प्रोटीन जब कोई भी प्रोटीन जब वो सिंथेसाइज होता है, उसका मूवमेंट, उसका ट्रांसलोकेशन फॉर ए स्पेसिफिक किसी एक स्पेसिफिक ऑर्गेनेल के लिए उस मूवमेंट को, उस ट्रांसलोकेशन को हम प्रोटीन टारगेटिंग कहते हैं. She is right. Absolutely, she is right. Anyone can translate the same in English. Fine. She has added two more words. Let it be inside the cell, inside the cellular organelles, or let it be outside the cell. There are certain proteins that comes out of the cell, isn't it? Can you give me an example? Any protein that is secreted in the form of vesicles that comes out of the cell, that is not functioned inside the cell. Many are there. Insulin. It's a peptidal hormone. It's a peptide. It's a protein. Collagen, isn't there? It is there or not? So there are many sort of proteins which are not targeted inside the cell, but rather they are packed into certain vesicles, fine, and they are moved out of the cell. This is also possible. Anyone else? Any further little more addition of words you can do? It's a very good discussion going on. I don't need that PPT also if this discussion continues. Anyone? Any better fine kind of words or vocabulary you have? I know you people have a better vocabulary than me. Moon, anything? She's sleepy. Your proteins are not getting targeted properly. They should reach the brain as soon as possible. Anyone? Yes, please. Bolo. Fine. Targeting also means you're targeting certain cells. That's nice. Okay. That can be another neighboring cell also. One cell provides certain protein that goes to the neighboring cell. Very good. Nice. Very nice. Okay. Fine. Now, in this whole terminology, yes, I accept that it is a mechanism through which set of proteins are transported inside the cell into different organelles or into different endomembranes or membranes of the plasma membrane or membranes of the organelles or inside the organelles, or they can be transported outside the cell in the form of vesicle. They are called as secretory proteins. Fine. But in this whole terminology, you have missed 2 points. Point number 1, did you thought that this protein that is being targeted to a specific cell occurs only when the protein is completely synthesized? Or the proteins are targeted when the protein is still undergoing synthesis? That means it is still attached to ribosome. There are two processes. One, the protein is completely synthesized. The peptide is completely synthesized. It has detached from the ribosome. You have got a set of polypeptide. Now this polypeptide has to be channeled into different area. Point number 1. This can also happen. Other way, what can happen is, the protein is getting synthesized. It is still attached to the ribosome and the protein is being targeted. कि भाई ये जो प्रोटीन बन रहा है इसको अपन ने टारगेट कर लिया है, ये जाएगा XYZ के पास. Is that clear? So there are two ways through which protein can be targeted or protein can be sorted out. Providedly, it has to be when the translation or when the protein synthesis is still continuing. Point number 2, when the protein synthesis is completely done, is completed. You have got an entire set of length of polypeptide chain. So now how you are going to define? It is a mechanism. Can you repeat with me? Can you all repeat with me? It is a mechanism of transport of matured protein or the protein yet getting synthesized to different organelles of the cell or the membranes of different organelles inside the cell or the plasma membrane of the cell or outside the cell. When we talk about outside the cell, when the protein is getting thrown out of the cell, it has to be going in the form of vesicles. Yes or no? Yes or no? Fine. So this is all about protein targeting. Now, protein targeting has been classified, जो कि हमने definition दिया, जो definition हम दिए थी, that is what? Either the protein can be targeted once the translation process is completed or when the translation process is going on. Fine. Number one classification goes as when the translation is completed. The ribosome has detached the chain of polypeptide that we call as post-translational targeting. What we call as post-translational targeting. Is it clear? Post-translation. Translation complete hone ke baad, post to that. Is that clear? Now, the second classification goes as co-translational targeting. What is that? Co, co-translational targeting. What does it mean? That the protein is yet getting synthesized, is still under the process of synthesis. It has not completely detached from the ribosome, but there are certain targeting sequences which has targeted that this protein that is going to get synthesized will be going to the specific organelle, will be going to the plasma membrane, will be going to the membrane of this organelle, or later maybe that can be secreted in form of vesicle. That is called as co-translational targeting. Is that clear? Is that clear? Now, this is the basic classification. Dependent on this classification, what we do that whenever we talk about post-translational targeting, there are certain cellular organelles that accept these proteins after the translation is completed. There are certain cellular organelles that accepts the protein to be targeted once or while the process of translation is going on. There are certain organelles. We have differentiated the organelles. Okay. So you can define, see, whether we were right. Please go through that. Whether we were right or not. We were right. What does it state? That it is a mechanism by which cell transport proteins to the appropriate position inside the cell or outside of it. Fine. We were right. In other words, the pathways by which proteins are sorted and transported to their proper cellular location are referred to as protein targeting or protein sorting. So we were right. Where they can be targeted, I have already told you, they can be targeted to the inner space of any organelle. They can be targeted to the membrane of the organelle, intracellular membranes. They can be targeted to the plasma membrane, and they can be also targeted or transported outside the cell. I just forgot about the history. The history is quite important. We will go to that. Basically, there was a physiologist, a very renowned physiologist called as Blobel, and he took an initiative with his all PhD mates. There were certain fellows who were doing PhD under him. He took a project to identify that why specific proteins are present in specific organelles. Why not DNA polymerase is present in chloroplast? Let us say, I know you have no need of chloroplast. I know. I'm just giving an example. Why DNA polymerase is not present in, kind of any other organelle? Peroxisomes, let it be. So he took this initiative in 1979, I guess. Yeah, 1970. And later on, his classmates or his PhD mates, not classmates, PhD mates, identified that there are certain set of sequences which explains that, okay, this protein is going to nucleus. There are certain sequences present in the peptide length that is going to peroxisomes. Certain is going to mitochondria. That was identified first by his PhD students. Okay. Later on, he worked on that. He worked massively in this area and found out that there are certain specific signal peptides or there are specific signal sequences that are present majorly in the end terminal of a peptide length or a protein. Majorly they are present in the end terminal of a peptide. Remember this point. I am going to highlight that later on. Fine. There are certain signal sequences. Now, if we talk about proteins, we are not talking about mRNAs or anything. We are talking about proteins. So what should be the signal sequences? What should be they composed of? Huh? Very good. Amino acid residues. Very good. If we talk about proteins, what do we have? We have amino acids. Nothing other than that. So there are certain specific signal sequences that explain that there are specific amino acids present in the end terminal end of a peptide that act as a signal sequence. Remember my point that these signal sequences vary from each other. if a protein that is getting targeted to, let us say, mitochondria will be having different set of amino acids. A protein that is getting targeted to nucleus will be having different set of amino acids. Or their arrangement may be different, their positioning may be different. Is that clear? But there is an exception again. The exception is that if any protein that is getting targeted towards peroxisomes, the signal sequences are not found in N-terminal, they are found in C-terminal. This is the only exception. Otherwise, if you talk about the entire set of proteins, all the set of proteins have got signal sequences in the N-terminal. Is that clear? Is that clear? And the exception, only exception is peroxisome. Is that fine? So, Blobel was the scientist or the physiologist who described that there are short sequences generally called as signal peptide or signal sequences that allows the targeting or that targets the protein to specific organelle, let it be in the plasma membrane or let it be the membrane of intracellular organelles or let it be whenever it is going out. So it is all decided by the signal peptides. Fine. And for that he has been provided with Nobel Prize in Physiology in 1999. Is that clear? कौन कौन पैदा हो गया था 1999 पे? कौन कौन पैदा हो गया था 1999 पे? तुम लोग कुछ करोगे ऐसा? Can you people, do you think like that? You can do this sort of thing, you can get Nobel Prize, any one of you? मत सोचो, फिलहाल फर्स्ट ईयर में फोकस करो. Okay. Coming to what is that signal sequences? I already told you that these are short sequences of amino acid, specifically or majorly is present at the N-terminal, but there is exception, that is peroxisomes. If any protein getting targeted to peroxisomes, the signal sequence is present towards the C-terminal. Okay. They are positively charged hydrophilic region near the N-terminal. When I talk about positively charged, what do you think the amino acid has to be? If I said that generally it is seen that these amino acid sequences are a length of 10 to 15 amino acids, generally 10 to 15 amino acids, and generally they carry positive charge. Then what sort of amino acid has to be there? Acidic? No. Anyone? What sort of amino acid it should carry? Anyone? Basic amino acids. Can we name them? Hey Baba. Very good. Arginine. Yes. Very good. Lysine. Anything else? Anything else? To some extent, leucine also. To some extent. To some extent. I'm not saying completely. Majorly, these amino acid sequences are in form of lysine, arginine, lysine. There is a repeated sequence of lysine, arginine. They act as a signal peptide. Okay. Whenever, see, as I classified you that what are the signal sequences, they are this sort of sequences that are present in N-terminal. To some extent, they are also present in C-terminal. But the only exception is peroxisomes, where we see the protein getting targeted is having signal peptides at the C-terminal. But there is one more thing. Interestingly, the proteins that are getting targeted towards nucleus, where the protein that are getting targeted towards the nucleus have their signal sequences in a unrepeated manner, stretch patches of signal peptides. Fine. And these signal peptides that are present in between, not at the terminal end, but in between the entire stage of peptide, they generally convey they have hydrophobicity in their nature. They are made up of hydrophobic amino acids. Now the question comes, sir, if the entire length of peptide has got the signal sequences not at the terminal end, but in between somewhere, how the signal sequences are going to get rid of? How we are going to read? Any idea? You got my question? You got my question? No. What I said, that signal sequences are generally terminal by nature. Either it is present at the N-terminal end or it is present at the C-terminal end. Fine. That's what I have told. There are certain proteins which are targeted to nucleus, do have their signal sequences between, not at the terminal end, but in between the peptide chain. Got my question? So how this in between patches, we call them as targeting patches. We call them as targeting patches. They are present in patches, patch form. थोड़ा सा यहाँ, फिर थोड़ा दूर और चल गया, फिर थोड़ा सा यहाँ पे signal sequence, फिर थोड़ा सा और चल गया दूर, तो फिर थोड़ा सा यहाँ पे. So these are patches of signal sequences. They are present in between, but not at the terminal end. And they specifically inherit this for the proteins that are getting transported to the nucleus. Now, how the cell recognizes If it is in the terminal end, it is easy to be recognizable. It is easy for the terminal end to read, for the cell or the transporters or whatever thing, we will talk about that later on. That is easy for them, for the proteins, to read the terminal sequences. But if the sequences are present in between the peptide, then how they are going to read? Because once the protein is formed, it is added upon by chaperones. Yes or no? For the proper folding. Yes or no? Right? So once the protein is formed, immediately they convey themselves into a proper folding stature. So how the patches are going to be identified? Anyone? तुम्हारे पास एक पेपर है, तुमने पेपर को कर दिया है फोल्ड, ठीक है, और उस पेपर के बीच में तुम्हारे प्रेमिका ने तुम्हें लिख के भेजा है कुछ, ठीक है, तुम्हें उसे देखना है, ना देखे मन नहीं भर रहा है, तो तुम क्या करोगे? क्या करोगे? पेपर को अनफोल्ड करोगे, तभी ना दिखेगा कि ऊपर से ही दिखने लगेगा, नहीं ना, यू हैव टू अनफोल्ड द पेपर. फाइन. सो व्हाइल यू आर अनफोल्डिंग, what does it mean in terms of proteins? Anyone? The proteins initially, to get their signal patches read by the specific proteins in the membrane, the proteins or the peptide has to be unfolded. They are supposed to undergo denaturation. Is that clear? Is that clear? So this happens majorly in case of nucleus targeted proteins. If the nucleus targeted proteins are not having their signal sequences at the terminal end, they are having their signal sequences in the form of patches. Yes or no? Are hi ya na bolo? Clear hai? See, what does it state that signal peptide? It says that after a protein has reached its destination, the signal peptide is generally cleaved by a signal peptidase. I'll give a beautiful example for this. And so most of the mature proteins do not contain signal peptide. Who of you remembers collagen synthesis? Who of you remember collagen synthesis? Be fast. Anyone? Pre-pro alpha chain? Yes or no? Signal peptides are removed, converts into pro-alpha chain. The pro-alpha chain coils around some more pro-alpha chains. Later on forms pre-collagen. Yes or no? That is better called as tropocollagen. That goes out. You remember? You remember? So when you are seeing a mature collagen, are you seeing the signal peptides or the signal peptides? No. Once the matured collagen is sent out of the cell, the signal, the terminal peptides are cutted off. They are removed. Yes or no? Let us talk about insulin. It has got a signal peptide. See, I was talking about patches. Just now I told you about patches, right? Signal patches. Insulin is the best example of explaining this answer. That what is signal patches? You have got A chain, B chain. You have got a terminal N signal peptide also. Apart from that, you have got a C peptide. Yes or no? Yes or no? C peptide is removed. So whenever you are seeing a mature insulin, does it contain C peptide? No. So C peptide act as a signal patch. Is that clear? While most of the signal peptides are found at the internal, I have already discussed, unlike signal peptides, signal patches are composed of amino acid residues that are discontinuous in the primary sequence but become functional when folding brings them together on the protein surface. Point to be noted over here. Whenever we talk about protein or targeting patches, I told you that targeting patches are made up of hydrophobic amino acids. Fine. So the stability of the hydrophobic amino acid is brought only when the folding is done. Fine. But to read out those patches for allowing the entry of those specific proteins into nucleus, we need to unfold it. We need to denature. But the stability of the protein containing signal patches in between, their stability is increased with the help of folding. Is that clear? This is what I have told already about the classification. Nucleus, we know, mRNA is produced by transcription. Ribosomes in the cytosol is responsible for the production of the protein. Fine. They are later on targeted into two different areas. If it is a completed protein, that is called as post-translational. Did I told you this? Yes or no? I told you about this classification. Now, in this classification, what you are supposed to remember is which are the organelles that supports post-translational, targeting, or they support co-translational targeting. Please, you have to remember this. Is that clear? Can you see? If it is a completed protein that is provided by post-translational targeting or transport, the targeted organelles are cytosol, nucleus, mitochondria, plastid, peroxisomes. If you talk about plants, chloroplast also is included in that. Please remember that. Fine. So if we are targeting a protein specifically to mitochondria, specifically to nucleus, the protein has to be targeted while the protein is getting synthesized or once the protein synthesis is over? The answer should be, if you are supposed to target certain protein to mitochondria or nucleus of the cell, the transport has to occur while the protein is getting synthesized or the protein synthesis is over. That last girl. Yes. কি বললাম বলতো? কি বললাম এখন বল? বল কি বললাম আমি? বাংলা বলছি তো। To the nucleus or to the mitochondria, it has to be transported after the translation is over or while the translation is going on. Simple, ওখানেই লেখা আছে, ঘুরিয়ে জিজ্ঞেস করছি। Apart from that, if you go to the secondary classification that we call as co-translational transport, which is generally responsible for those proteins targeted generally outside the cell, majorly outside the cell, where we play Golgi apparatus or Golgi bodies plays a very important role. So if you talk about co-translational targeting, the first example it should come to your mind is Golgi bodies. Yes or no? Is that clear? Or any any protein that has to be targeted outside the cell, that undergoes co-translational modification. While co-translational targeting, what does it mean? That the targeting of the transportation of protein occurs only when the protein is still under synthesis. Yes or no? Clear? Mechanism 1, that is what? It is post-translational transport. I have named it as mechanism 1. Fine. It generally occurs in the cytosol and it occurs only when the protein has already got synthesized. That is called as post-translational transport. Okay. You should remember the names as an example. Nucleus, mitochondria, peroxisomes are delivered by this process. Please. They will ask you this in short questions. Sorry, this is also asked for multiple choice questions. Mechanism 2, that generally occurs, now where the protein synthesis is occurring? RER, rough endoplasmic reticulum, that has got ribosomes. It is still attached to that. Fine. And that is called as co-translational transport, also called as secretory pathway. That is what I am calling it as from the beginning time, that whenever we talk about the proteins that are targeted to neighboring cells, they are transported with the help of vesicles, in the form of vesicles. The vesicles are secreted out. That is why we call them as secretory pathway also. Okay. 30% of the protein are shorted by this secretory pathway. That is quite vital for us, including secreted proteins, residents of endoplasmic reticulum, Golgi complex, lysosomes, and integral membrane proteins. See, cytosolic protein targeting, that means it is post-translational targeting and it is happening only when the translation is covered. The entire translation process is completed. Fine. I have already discussed that whenever a protein has got synthesized, it has got certain signal sequences. Either it can be at the N terminal, either it can be in the C terminal. To some extent, they can be present in form of patches in between the entire length of peptide. Fine? Yes or no? So, a protein carrying signal peptide, we always call that with the help of a terminology is there, we call them as a pre-protein. What we call them as? Insulin, you remember? Insulin, you remember? What is the first basic form of a completed protein? Insulin. Pre-pro. Is that clear? So, any form of protein in which the signal peptides are still there, we call them as pre-protein. After the cell, dependent on the signal sequences, after the cell has localized or has transported the protein into specific compartment of the cell, the signal sequences are removed with the help of signal peptides. That protein is called as a native protein. So, pre-protein minus signal peptides or signal sequences is equal to native protein. Is that clear? Is that clear? Important. Now, थोड़ा सा हम लोग डिटेल में आते हैं. How the proteins are targeted to mitochondria? There are certain transporters. Point to be noted over here. Mitochondria is a very vital organelle in terms of it has got two different membranes. Yes or no? outer membrane, inner membrane, and they are segregated with the help of intramembrane space. Yes or no? So if a protein has to be targeted to mitochondria, the difficulty is more. Why? Because it has to cross two gates. It has to cross two barriers. Now, not all the proteins are destinated for the matrix of the mitochondria. Some of the proteins are destinated for the inner membrane. Some of the proteins are destined for the outer membrane. Some are destined for the inner membrane space. Some are destined for the matrix. So there is a difference. How this differentiation is maintained? With the help of certain another proteins, with the help of certain another transporters. Okay, and those transporters are named as, these are named as protein translocators. What they are named as? Protein translocators. They are generally multi-subunit protein. Have you heard about multi-subunit or multi-enzyme complexes? Have you heard about PDH complex, right? Yes. Anything in the TCA cycle similar to PDH complex? Alpha keto glutarate dehydrogenase. Yes, that is a bhai of PDH complex. The only difference between these two enzymes, PDH complex and alpha ketoglutarate dehydrogenase, is that in PDH complex the first enzyme is pyruvate dehydrogenase, and in the second case for alpha ketoglutarate dehydrogenase the first enzyme is alpha ketoglutarate dehydrogenase. That's it. The only difference. Otherwise remaining everything is same. Fine. So like that, these proteins, these protein translocators that are responsible to translocate a protein into different part of a mitochondria, let it be inner membrane, outer membrane, intramembrane space or matrix, they require certain proteins that are called as protein translocators, and they are multi-subunit complexes. There's a multi-subunit proteins made up of different parts or different constituents. The first one says as TOM, classification as TOM, team 22, team 23, and the last one is OXA. TOM stands for translocator of outer membrane. Simple. TOM stands for translocator of outer membrane. TEAM stands for translocator of inner membrane. Simple. Fine. And the OXA stands for? OXA stands for? What should be the full form of OXA then? Anyone? TEAM stands for inner membrane, TOM stands for outer membrane. Then what is OXA? It translocates or allows the insertion of inner membrane proteins. There are certain classifications apart from TIM or TIM. There are certain proteins which specifically relies or which allows the transport of proteins into the inner membrane. There is a subclass. You can call it as a subclass. Okay? Is that clear? Apart from that, team 23, being a translocator of inner membrane, is also responsible to translocate the protein into matrix. So whatever matrix enzymes or proteins that you see, all the enzymes except one of Krebs cycle are present in matrix. Yes or no? All the enzymes of TCA cycle except one is present in matrix. What is the exception? Succinate dehydrogenase. Succinate dehydrogenase is hanging from the inner membrane and facing towards the matrix. But it is not a cellular enzyme or it is not a functional enzyme of matrix. Okay. Now, protein targeted to nucleus. As I told you that it has to carry some signal sequences, and these signal sequences decides that where it is going to get translocated. So like that, the proteins that are going to get translocated to the nucleus has got certain specific signals. We call them as NLS, nuclear localization sequences. Please remember these terms, NLS. There are many drugs that specifically work on that. It has got a very high importance in pharmacokinetics and pharmacology, basically. Clear? Please remember these terms, NLS and also there are different drugs targeting these transporters. This nuclear localization sequence is basically made up of 4 to 8 amino residues, and that has to be basic. I told you this. I told you about that the amino acid should be carrying positive charge. Most of the time it is seen that the amino acids are in form of arginine and lysine. There are repeated sequences of arginine and lysine. Fine. Now, this entire protein targeted to the nucleus having NLS or nuclear localization sequences are allowed to come inside the nucleus with the help of another protein that is called as nuclear pore. That is called as nuclear pore. So, nuclear pore decides what is the signal sequence. Fine. Apart from that, these nuclear pore complexes, there are multiple units of nuclear pore complexes, have got a specific protein that reads the NLS, that is called as nucleoporins. कितना कुछ बोल दिया देखो. NLS is present in peptide. Nuclear pore complexes is present in the nuclear membrane. Fine. Who reads the new NLS provided in the peptide sequence? That is read by nucleoporins. So nucleoporins reads that, allows the entry of protein inside the nucleus through the nuclear pore complexes. Is that clear? If, for example, there are certain nucleoporins like importins and RAN, very targeted proteins again, lot of targeting therapies and a lot of things, new drugs are coming out to target this sort of proteins. If you talk about importins, they are responsible to import or internalize any protein. If we talk about exportin, that are responsible to export out or send out any protein out of nucleus. Clear? Peroxisomal transport, the only thing that I have told, signal recognition sequence or signal sequence, signal recognition particle, SRP receptor and the transport. Follow the diagram. At the top corner, at the top side, you can see a ribosome attached to the mRNA. Yes or no? Yes or no? Later on, you can see that the polypeptide chain is getting synthesized from the ribosome, a small chain. Yes or no? It has got an N-terminal. Yes or no? It will get an N-terminal. That N-terminal has got a signal sequence. Let us assume that it has got a signal sequence. And now, is the peptide getting targeted right now is completely synthesized? Yes or no? No, right? That's why we are calling this mechanism as co-translational transport. Fine? The protein is not yet synthesized. During the process only, we are targeting it to certain complex, certain organelles. The moment the first signal sequences comes out from the ribosomal complex, a molecule is there that is called as SRP, signal recognition particle, that binds to the signal sequences present in the short chain of polypeptide. Can you see there? It binds in such a way that this SRP has got two binding areas, one for the signal sequences, another for the ribosome. So it binds all together. It binds both. During the binding of SRP provided to the ribosome and the signal sequence present in the polypeptide chain, the translation halts. The protein synthesis halts. Important process. This is a checkpoint. This is how the cell decides that, okay, this protein is going to Golgi body. This protein is going to get transported with the help of vesicles. This is the checkpoint. Fine. So this SRP bound to the ribosome and the signal sequences are brought to a receptor called as SRP receptor, signal recognition particle receptor, that is present in the rough endoplasmic membrane. The moment SRP binds with the alpha subunit of the SRP receptor, the translation begins. The translation begins. Fine. Once the SRP binded to the SRP receptor allows the translation to begin, another one more protein comes in play, that is called as translocone. That is called as translocone. Translocone is nothing but a pore, एक hole है. It's a pore that allows the internalization of advancing polypeptide chain. Can you see? The polypeptide chain enters. Is that clear? And the translocone is not always open. The translocone opens up only when the SRP binds with the SRP receptor. Fine. So once the polypeptide chain is internalized, the translation keeps on going, the entire protein length is produced and the entire polypeptide chain is provided inside the rough endoplasmic reticulum for further modification. The first initial modification that occurs in rough endoplasmic reticulum is the signal peptides are removed with the help of enzyme called as signal peptidases. Is that clear? Is that clear? So this is co-translational modification. The last part comes as very important for you, generally comes in the form of multiple choice questions, and also to some extent they might confuse you. They may ask you about these deficiencies, but you may write the wrong answer. Regarding how? Like how it is possible? Disorders associated with protein targeting. The first, due to defect in mitochondrial targeting sequence, very important, primary hyperoxaluria. Primary hyperoxaluria type 1. Have you read about it? Now why it is happening? See, there is an enzyme called as AGT, alanine glycoxylate transaminase type 1, that is generally peroxisomal by nature and that is present in hepatocytes. But if there is a problem, any mutation or any change in the signal sequence where this enzyme or this protein AGT has to come into peroxisome, but let us say it went to mitochondria. Now what happens? There will be a deficiency of this enzyme in the peroxisome. Because of that, there will be no conversion of glycoxylate. Fine. As a result of that, they will start accumulating. Glyoxylate will start accumulating in the blood. They will convert themselves into oxalates. This oxalate will combine with calcium. They will form calcium salts. These calcium salts are responsible for renal calculi seen in hyperoxaluria type 1. The renal stones, what we see in case of this condition, is because of the formation of calcium oxalates due to deficiency of that. And why this is happening? This is happening because of mistargeting or targeting error. That can be because of any mutation. Is that clear? Next one. PDS deficiency. You all know, sir, PDS deficiency. Have you heard? Hemolytic anemia. We all know. Fine. PDS deficiency is one of the most commonest seen disorder due to mistargeting of protein. Most commonest. It was recently found out, by the way. It was recently discovered, but most common. Why this is happening? Due to deficiency. There is a mutation in that protein transporter that is called as NMTS. You can see, you can see there are certain TOM complex. I told you about the TOM complex, team 22, team 23, OXA. I told you, no? So these are all transporters that allows the protein inside the mitochondria. So if any mutation takes place in provided these proteins, these translocators, this protein translocator, these enzymes, proteins cannot come inside the mitochondria. The most commonest out of it is PDH or pyruvate dehydrogenase complex. Is that clear? If I talk about disorders due to defect in peroxisomal matrix protein import, in whole total we call it as Zellweger spectrum, out of which the most commonest is Zellweger syndrome. I think you are aware of it. You know what is Zellweger syndrome. Very common question, short question. Another is neonatal adrenoleukodystrophy. They do ask this thing. The last one is infantile refsum's disease. the least severe. This is called as Zellweger spectrum. Now, most commonest symptom of Zellweger spectrum, do you know? What happens in Refsum's disease? What happens in Refsum's disease? Anyone? Accumulation of what? The most commonest symptom that we see in case of accumulation of long chain fatty acids in the peroxisomes. Most commonest symptom. Is that clear? All of you?
So many times I told you to write everything and read. If you don't do that thing, you will not remember. Now this will be a spotter or it will be given as a viva. So this type of cards will be given. The questions will not be the same. But in this slide, whatever is written here, I have just projected. And everything is, will not match also. So there will be changes, but the basic concept is like this. This is the first case. What is your diagnosis? Diabetic ketoacidosis. As already it has been explained well, all the regions, blood glucose normal value, it is more than, significantly higher than, it is normally, I repeat, blood sugar is not written. It is written as plasma glucose. Blood sugar is a very loosely used term. Till doctors say blood sugar. If you make from finger pricking, from the whole blood, that is blood glucose, and in the laboratory, what is measured? Measured is from plasma, that you have estimated, that is plasma glucose. So all the interpretation as per WHO criteria are based on plasma glucose. Okay, the plasma glucose level is 10 to 15% higher than whole blood glucose. That you remember. Blood pH normal value you must remember. Range, here it is low. Bicarbonate normal value you must remember because it could not compensate. This is an uncompensated case. So it is a frank case of diabetic ketoacidosis. Why it has happened? Because Rosaria test is positive, because ketone bodies has been formed. And number 4 is Benedict test. I have explained you in detail what is the renal threshold, what is TMG. When it will be exceeded, then renal tubules will not be able to absorb and urine will appear. The differentiating point has a catch question. Those who will be able to answer to this question, he will be asked what is the difference between starvation ketoacidosis and diabetic ketoacidosis. You have to tell this difference. Now, এই যে তুমি বলবে এদিকে স্যার এই যে starvation ketoacidosis কি হবে? What will happen if it is a starvation ketoacidosis? If it is a case of starvation ketoacidosis, দুটোতে ketoacidosis হয় in both the conditions, either in diabetic or in starvation. In both the conditions, ketoacidosis will be there. One is really poverty in appearance, that is diabetes. One is really poverty in poor condition itself. বলো কি চেঞ্জ হবে বলো ইয়েতে starvation ketoacidosis নয় কেন এটা বলো দাঁড়িয়ে বলো what will be the picture if it is a case of starvation ketoacidosis? Blood glucose level will be less than normal level. And what other abnormality will be there? What will be other abnormality in this report? ভাই ওখানেও ketoacidosis হচ্ছে starvation ketoacidosis, একটা প্যারামিটারে চেঞ্জ হবে। Benedict test will be negative. এখানে গ্লুকোজ লেভেলটাই কমে গেছে এবং জানবে মনে রাখবে if there is significant hypoglycemia for a prolonged period of time, then only diabetic ketoacidosis will occur. This starvation ketoacidosis will occur. Now body will try to maintain through glycogenolysis, through neoglucogenesis. When the entire reserve will be depleted, then only hypoglycemia will occur. Remember, whatever classes I have taken, all the classes will be required in your clinical classes. I deliberately have concentrated on the clinically relevant topics. So remember everything. You will remember the diabetes I have taken. I have taken OGDT class also and explained in detail. And nothing will be required in your MBBS course. Practical aspects I have covered, even by giving case example. Second case, so first point is comment on the report. As you have seen earlier, this case also, T3, T4, TSH. Look at this thing, forget about cholesterol. Cholesterol may be given or may not be given. Cholesterol value may be normal also, but deliberately it has been given since this is a case of, it is a common belief that hyperlipidemia occurs in, or hypercholesterolemia occurs in primary hypothyroidism. That's why this figure has been given. Normal cholesterol level, again, NCP guidelines, you must remember what is normal cholesterol, normal triglyceride level. NCP guidelines, National Cholesterol Education Program, guidelines you write down. This you remember. This will be asked. What is the value of HDL, LDL, VLDL, HDL, LDL, cholesterol, triglyceride? This level you have to remember. And the criteria, ADA criteria of 2024 and WHO criteria of 2022 are the same for fasting impaired, this normal impaired and over diabetes, fasting PP and H1C. H1C is today, everybody is talking about H1C. So examiners might ask you what is the normal H1C, what are level, what is the normal level, and what is the clinical relevance, and what is the difference between fasting PP and H1C in a given diabetic patient. And if you cannot understand, I can take one more class, no issue. But blood sugar, blood glucose level and diabetes you must remember. So what is the probable diagnosis? Hypothyroidism. If you cannot write primary, secondary, at least write hypothyroidism. Don't write hyperthyroidism. Then it will be 0. Hypothyroidism means it will be almost 80% marks. Basically, you are correct. But those who will be writing primary hypothyroidism, obviously he will be getting 100%. Because now he knows the actual problem. If you are in a doubt, don't write primary or secondary. Write the diagnosis of hypo or hyper. Okay? That means your concept is at least clear, you could diagnose. Because the treatment part of both are different. Of either primary will be basically replacement therapy, a secondary will require a surgical treatment because this will be due to usually tumor. So pituitary is located on sphenoid bone. So from brain it cannot be approached. Transsphenoidal approach through nose. Pituitary gland is accessed and this is removed if there is any tumor. Okay. Explain the cause of increased TSH. Someone should volunteer. That is a catch question and you must understand this thing. বলো একজন কেউ বলো একটু আগে তো বলে দিলাম জোরে বলো শুনতে পারবে বলো ঠিক it will not increase, it will stimulate the pituitary gland more TSH in an attempt to compensate basically to raise T3 and T4 level. So what is the function of TSH? To cause increased production of T3 and T4. How? By doing hypertrophy and hyperplasia of thyroid troughs. Okay? So pituitary will try initially to increase by raising the TSH level. Now, in the initial phase, T3, T4 will be normal because it is not trying to compensate. Now, there is a limit. Suppose there is 100 T3, 100 T4, you need forget, and 100 TSH is increased, this is normal level. Now, T3 has decreased. See, again, I am remembering the 80% of T4 is produced by the thyroid gland and 20% of T3 is produced by the thyroid. Peripherally, T4 is converted into T3 and T3 is the active form. See, earlier I told you if the gland is primarily involved, that is primary. If pituitary is used to be involved, that is called secondary. And if hypothalamus is diseased, that is tertiary. Now these two terminology has been removed and there is a classification of primary and central. So you all concentrate on primary and central. Don't write that because this term has been obsolete. What has happened basically from the thyroid gland, if there is a decreased production of T4 and T3, there will be stimulation by the TSH and also TRH. Because TSH secretion is under regulation of by the hypothalamus through TRH. So TRH has to be secreted, it will stimulate the pituitary and more TSH will be formed. So the less the T3 and T4, the more the TSH level and TRH level. Now there will be one stage when compensation will not be able to sufficient, at that time it will decrease. And the more the decrease, more the level of TSH. Okay? So the higher the TSH means a gland is maximally stimulated, perhaps it could not compensate, and the moment you give a thyroxine, L-troxin, there will be reverse feedback, and if you give T3, T4 orally, T3, one thyroxine if you give orally, then this level will increase in the blood, and that will inhibit that there is no more requirement of TSH. It is already there in the system. So if you see a very high TSH level, maybe the thyrotroph in the pituitary has undergone severe hypertrophy and hyperplasia to produce as much TSH as it can. So explain the cause of increased TSH, you must be able to know that feedback system. If you can't understand, again read from the books. If you cannot understand, again I come. No issue. One or two, three, four, five students that come. It will not be a matter of any issue. I will be present in the next week also. So, what are the clinical features? Clinical features are very vague. I am telling you, there is no specific symptom for hypothyroidism. Their patient comes with lethargy, tiredness, constipation, decreased appetite, hair loss, skin thickening, weight gain, menstrual problems, endless symptoms. And there is no specificity, except one thing, one is goiter. So I have shown you in the theory picture that how goiter looks like. If you look at the gland, everyone make it a habit that you look at the gland, neck person, this is the exposed person, and the moment somebody regulates, and you look at that position below the cricoid cartilage. Don't confuse it with thyroid cartilage. It is below there, and you will see butterfly shaped, or there will be nodule which will be moving. That means the gland is increased. And why gland is increased? Because again the gland is diseased. Okay. So you can see a goiter also. Goiter can lead to hypothyroidism, goiter can lead to hyperthyroidism also. Any enlargement of thyroid gland is called goiter. It can be euthyroid also. Because during one stage, this has occurred, now body has stabilized that thing. So T3, T4 will be normal, TSH will be normal, but there will be an increased gland. That means somehow insult was there, body has tried to compensate it, so that still enlargement is there. That enlargement will remain. Okay? So, what other tests are done in this condition? Usually, this normally, where I told you in the theory class also, when the iodine is an essential element for production of thyroid hormones. So we don't have any iodine deficiency because today we are all taking iodized salt. Oh, we don't have any iodine deficiency. Whatever goiter we are seeing today is not an iodine deficient goiter, unlike Easter years before 1985 or before 1990, when iodized salt was not available throughout in the market. We used to take salt in the given in the rack with non-iodized salt. So during that time, iodine deficiency could be possible, but now it is not. Where there is an iodine deficient in the geochemically in the soil, you will get a goiter that is iodine deficient goiter. And when iodine is present in adequate amount, the goiter usually is an iodine sufficient goiter, and this cause of the iodine sufficient goiter is autoimmune. That means some antibody, autoimmunity has occurred against the thyroid gland itself, against one of its antigen. So common antigen is anti-TPO, thyroxine peroxidase. So that is basically oxidizing that iodine, that TPO antibody, that against the TPO there is an antibody production. So that antibody will react to the TPO. So that TPO will cause there will be immune reaction, and because of the immune reaction, there will be inflammatory swelling. So anti-TPO antibody is the one parameter you write down, and it is routinely done. When a case of hypothyroidism is presented, anti-TPO antibody is measured, and this level will be high. In this case, it will be high because the disease is quite advanced. TPO level is low. Second thing is that you can do an antithyroglobulin also. Again, it will cause damage. Third one is lipid. There will be alteration of the lipid metabolism. So cholesterol, triglyceride also you check it. And fourth one will be diabetes. See where where there is any incidence of diabetes also there, because this is an endocrine disease, so it's autoimmune disease. There is a possibility that autoimmune mechanism has also destroyed the pancreas to some extent. It is a possibility, not always associated. But with hyperthyroidism, there will be an decreased tolerance of glucose, and usually there will be a diabetes, and that diabetes will be cured. That is called a secondary diabetes mellitus. I explained this thing in the theory class also. Okay, what other tests will be done? Anti-TPO antibody. This you must tell. Second, one more question, anti-thyroglobulin antibody and lipid profile also. এটা বোঝা গেল তো? এটা বুঝতে পেরেছো এই জিনিসটা? বই একবার পড়ে নেবে। ওকে, এইটা বলো 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 এদিকে এসো, এদিকে এসো, তুমি এসো। বলেছো তো ঠিকই, বলো এদিকে এসো, আন্দাজে বলে তোমাকে ছাড়বো না, এদিকে এসো। হ্যাঁ, urine dipstick টা আমরা urine করার সময় পড়েছিলাম। I have told you that in the Benedict test, all the reducing sugars will be present, positive. Even some ascorbic acid, vitamin C I have shown you, and some drugs are also can give a false positive reaction. It is not a specific test. So glucose oxidase impregnated strip, I mean these are available. Anybody can pass urine directly on the strip, or it can be just dipped into the urine. So you can see the change in the color. If there is a glucose presence in the glucose, that will be positive. বসে পড়ো, বসে পড়ো। প্রথমে কেসটা দিকে তাকাবে। Child with cataract, first diagnosis make galactosemia. Child এর cataract হয় না গো। Cataract occurs in the older age group, usually more than 50, more than 60, 70 also. It's not an unusual feature. Child with cataract, first diagnosis in the question, galactosemia. And then think something, first concentrate on that thing and rule out whether something else is not there. Okay? So here, you see inability to see the objects clearly because lens টা opaque হয়ে গেছে, তার জন্য দেখতে পাচ্ছে না। আই এক্সামিনেশন রিভিল ক্যাটারাক্ট। এবার কেন হয়েছে বলো, বেরিয়াস পজিটিভ হয়েছে, ঠিক করে বুঝতে পারলে যে এখানে ব্লাড গ্লুকোজটা কমে গেছে। হাইপোগ্লাইসেমিয়া ইজ এ ফিচার, but it will not occur always. But this is one feature I am telling you. You must know why blood glucose level is low. You read it. Benedict test is positive. কেন Benedict test কেন পজিটিভ হলো বলো? একজনকে তুমি বলো কেন Benedict test পজিটিভ হলো? Benedict test গ্লুকোজে পজিটিভ হয়, এখানে কেন পজিটিভ হলো? ও তো ডায়াবেটিস স্যার, এটা গ্যালাক্টোজ পজিটিভ দেবে তো। Benedict test, whether galactose will give a positive Benedict test or not. Bolo, all monosaccharides having a free aldehyde or free ketone group, all disaccharides which are having a free alcohol except sucrose. Remember, all monosaccharides which are having a free aldehyde or free ketone group will give a positive result. Galactose is a monosaccharide. So therefore, galactose will give a positive blood sugar. And out of the three trisaccharides, lactose, maltose, and sucrose is a non-reducing sugar because it doesn't have a free aldehyde or free ketone group. That is bound by glycosidic linkage. Remember that thing. Okay? So because galactose is positive, why galactose has appeared in the urine? Why galactose has appeared in the urine? Lactose কোথা থেকে পেলে এখানে? আচ্ছা ইউরিনে কি জন্য আসছে? যে মেকানিজমে গ্লুকোজ বেরিয়েছে ইন ডায়াবেটিস, সেম মেকানিজম। There is a limit, there is galactosemia, so galactose level is increased in the blood, that has been filtered by the kidney and that is appearing in the urine. What is the provisional diagnosis? Galactosemia. How do you explain cataract formation in this case? Accumulation of dalcetrol. That sorbitol pathway you must remember. And what will be the case in the case of diabetes? That is sorbitol. This pathway remember, এই পলিওল পাথওয়েটা মনে রাখবে, অ্যালডোড ইজ ডিরেক্টেড। এই গ্লুকোজ থেকে সরবিটাল তৈরি হয়, and sorbitol is an osmotically active substance. And in diabetes because of the excess glucose, sorbitol is produced by the lens fibers, lens cells, and it accumulates. This is an osmotically active substance, and that causes increased accumulation of water, not only in lens, but in every cell, and that is the cause of complications of diabetes. So if you regulate the blood glucose level, then this sorbitol formation will not be there, so complication will be less. That is the basic fundamental mechanism of damage and complications in diabetes. Sorbitol formation, and in the same way, galactitol or dalcetrol is formed in the galactosemia case. এই পাথওয়েটা, এই দেখো এই পাথওয়েটা পড়বে। আচ্ছা কি কজ? প্রথমত কজটা জিজ্ঞেস করবে, অ্যাটলিস্ট এইটা বলবে, ঠিক আছে? গ্যালাক্টোজ 1-ফসফেট ইউরিল ট্রান্সফার, এইটা বলবে। তারপরটা বলবে গ্যালাক্টোকাইনেজ। এই রিয়াকশনটি জিজ্ঞেস করবে, এই রিয়াকশনটা লিখবে, ভালো করে মুখস্থ করে নেবে, বইয়ের মধ্যে লেখা আছে, ভালো করে পড়বে। শুধু মনে রাখবে এই পাথটা কিন্তু বাইডাইরেকশনাল পাথ আছে। অ্যাডাল্টে 4 বছর পরে মোটামুটি এই ইয়েটা চলে যায়, এটা দরকার পড়ে না, গ্লুকোজ গ্লুকোজ থেকে ইউডিপি গ্যালাক্টোজ তৈরি হয়ে যায়, সেই জন্য বেবিতে এই প্রবলেমটা হয়ে যায়। এই জন্যে এ দেখো কোশ্চেনটা আরো দেখো, how will you explain the cataract formation? Through dalcetrol formation, and that is an osmotically active substance because excess galactose cannot be metabolized, so that will be formed in the conversion into dalcetrol through sorbitol pathway. Write down that pathway, and that will increase osmotically active, will cause formation. How will you confirm the diagnosis? সাসপিশন হয়ে গেছে, সব কিছু হয়ে গেছে, মানলে এবার কনফার্ম তো তোমাকে ডায়াগনোসিস করতে হবে। এটা একদম খুবই দরকার, কারণ বেবিটা তো মারা যাবে যদি গ্যালাক্টোসিড ইউরিল ট্রান্সফার যদি ডেফিসিয়েন্সি না, যদি ট্রিটমেন্ট না করতে পারো, মিল্ক যদি অফ না করতে পারো, 1 সপ্তাহের মধ্যে মারা যাবে বেবিটা। So this is a rare disease, but there will be severe problem with jaundice and there will be death also. So how will you confirm? তাহলে তোমাকে মাপতে হবে গ্যালাক্টোজ মাপতে হবে ব্লাডে। ডিফিকাল্ট শর্ট করে হয় না, গ্যালাক্টোজ 1-ফসফেট ইন এরিথ্রোসাইট ইজ মেজার্ড, একটা প্যারামিটার। সেকেন্ড হচ্ছে এই যে গ্যালাক্টোসের ইউরিল ট্রান্সফার গ্যালাক্টোকাইনেজ, এই এনজাইমটা মেজার করা যেতে পারে, অথবা এর কনসার্ন জিনটাকে মিউটেশন আছে কিনা দেখা যেতে পারে। কনসার্ন জিনের মিউটেশন আছে কিনা, তাহলে এটা প্রিনেটালি ডায়াগনোসিস করা যেতে পারে। যখন বাচ্চাটা মায়ের পেটে আছে, একটা লাইকার অ্যামনিও নিতে পারে, সেখান থেকে অ্যামনিও সিন্থেসিস করলে সেখান থেকে সেল পাওয়া গেলে, সেই সেলগুলো ফিটাল সেলই, সেই ফিটাল সেল থেকে করা যেতে পারে। সেখানে আমি যদি জেনেটিক স্ক্রিনিং করি, জিনের ডেফিসিয়েন্সি যদি পেয়ে যাই, আমি ওই গ্যাল জিনটা নেই, বা গ্যাল জিনটা মিউটেটেড, বা গ্যালাক্টোকাইনেজ জিনটা নেই, তাহলে তো বেসিক্যালি এটা গ্যালাক্টোকাইনেজ আছে। আর লেভেলে কি কিছু কোনো ফ্যাক্টরি থাকে, ঠিক আছে? এটা সহজ না, বললি ওই মিউজ লিখেছি, ঠিক আছে? ইউরিন গ্যালাক্টোজ, তাহলে ক্রিস্টাল দেখতে পাবে পুরো সাদা, মিউজিক ক্রিস্টাল হিটিং ইউরিন উইথ নাইট্রিক অ্যাসিড, এটা কিন্তু করতেই পারবে, তুমি মাইক্রোস্কোপের তলাতে দেখতে পাবে। Why early diagnosis followed by dietary management is essential in this case? গ্যালাক্টোজের সোর্স বলো বডিতে, কোথেকে পায়? একটা বেবি, হ্যাঁ, মায়ের দুধ খাবে, মায়ের দুধে ল্যাকটোজ আছে, তাহলে ওই ল্যাকটোজ থেকে গ্যালাক্টোজ তৈরি হচ্ছে। তাহলে ফার্স্ট কাজ হচ্ছে মায়ের দুধ খাওয়া বন্ধ করতে হবে, বন্ধ করতেই হবে, তাহলে এর হাত থেকে রেহাই নেই। তাহলে বেবি নিউট্রিশন পাবে, গ্লুকোজ খাও, নিউট্রিশন তো বেবিকে দিতে হবে, প্রোটিনও দিতে হবে, অ্যাটলিস্ট মিল্ক প্রোটিন তো ডাইজেস্ট করতে পারবে ওইভাবে। আমরা তো ওই কাঁচা দুধটা খেতে অভ্যস্ত আছি মায়ের থেকে, অল ট্রু ফর অল ম্যামালস। সো ম্যানেজমেন্টের ইসেন্সিয়াল কেন? আদারওয়াইজ ব্রেন ড্যামেজ হবে, মেন্টাল রিটার্ডেশন হবে, বেবিটার ডেথ হবে। সেই জন্যে একটা অ্যাগ্রেসিভ ট্রিটমেন্ট করা দরকার আছে এই গ্যালাক্টোসিমিয়া কেসে। এই চারটা মনে রাখবে ভালো করে। এটা আগের দুদিনের ক্লাসে আমি বলতে পারিনি গো। এইটা বলো, বল তুমি জোরে বলো, জোরে বলো। প্রাইমারি হাইপারথাইরয়েডিজম, রিমেম্বার, একদম অ্যাবসলিউটলি কারেক্ট ডায়াগনোসিস। হ্যাঁ ঠিক। কেন T3T4 বেশি বেশি হয়েছে বলো? কেন T3T4 বেশি হয়েছে? থাইরয়েড গ্ল্যান্ড ইজ ওভার অ্যাক্টিভ। থাইরয়েড গ্ল্যান্ড ইজ ওভার অ্যাক্টিভ, ঠিক আছে? তাহলে ওভার অ্যাক্টিভিটি অফ থাইরয়েড গ্ল্যান্ড উইল কজ T3 and T4। তখন কি হবে? T3T4 যদি বেড়ে যায় তখন কি করবে? ও TSH কে নেগেটিভ ইনহিবিশন করবে, যে তোমার আর দরকার নেই TSH তৈরি করা, আমি অ্যাডিকুয়েট, আমার থাইরয়েড তৈরি হয়ে গেছে। All of you are Bengali, I am speaking a good amount of, I mean, is there any non-Bengali? Is there any non-Bengali who cannot understand? I mean, can you understand? You could. Otherwise, I have to, okay, let me, see, if their T3T4 production is normal, remember one thing at the end, I am concluding this class, if T3T4 is normal, then there will be normal secretion of TSH and normal secretion of TRH. If the T3T4 secretion is low, it will be low because when the thyroid gland itself will be decreased, underactive, I repeat, it is not a normal active but underactive, then there will be feedback regulation, positive regulation, that will stimulate the hypothalamus to release more TRH, and then which will stimulate the pituitary gland to secrete more TSH, and because of that thing, more TSH will be formed. In primary hyperthyroidism, gland is hyperactive. That's why it is producing more T3 and T4, and it is causing a negative feedback. No more production is required, that is causing less TSH. In primary hyperthyroidism, it is due to pituitary tumor or mainly. Excess amount of TSH is produced by the thyroid producing cells. That excess amount of TSH will increase thyroid gland to function more. It will indirectly make it more, that is secondary hyperthyroidism. This is central hypothyroidism. And if it is less, then it will be more, then it will cause primary hyperthyroidism. And if the thyroid gland, the pituitary gland doesn't function at all, TSH level will be low, and so thyroid gland will not be able to function properly because there is no more, or TSH amount is less. Despite thyroid gland being normal, thyroid gland will not be produced adequate amount of T3 and T4. Is this part clear? So I conclude, and this is the end class for your session. So all the best for your examination. Pass. I wish that you pass. So all pass.
In details, basal ganglia and internal capsule. You have seen one in viscera. These structures I have shown you in the viscera. So today we will discuss. These are important for your long question. Both the topics are important for long question. Okay. Internal capsule, very frequently given question. Basal ganglia also counts. And Parkinson's disease is clinical aspect of the basal ganglia, that is also an important long question. Okay, so basal ganglia, basal nuclei or basal ganglia, these are the large masses of grey matter situated in the basal part of the white matter of the cerebral hemisphere. So this part is forming the basal ganglia or basal nuclei, and here is the thalamus. It lies in close relation with the thalamus, and these are large masses of grey matter. You remember it? It is a mass of grey matter situated in the basal part of the white matter of the cerebral hemisphere. Next is components. Components are very frequently asked in your viva also. If brain viscera, components can be asked in your viva. Components and functions are important for viva. Also theory it can come. So basal nuclei include corpus striatum. Corpus striatum consists of the caudate nucleus and lentiform nucleus. Lentiform nucleus again formed by two parts, globus pallidus and putamen. Next, including the claustrum and the amygdaloid body. So basal nuclei include the corpus striatum, claustrum and amygdaloid body. Now what are the functions of the corpus striatum? Corpus striatum forms a part of extrapyramidal system and controls the muscle tone, posture and quality of the movements. Amygdaloid body forms a part of limbic system and performs role in emotional and motivational aspects of movements. Functions of claustrum is not known. So three parts and their functions. This part function is not known. So these are the components and here are the functions. Components are corpus striatum, claustrum and amygdaloid body. Corpus striatum consists of caudate nucleus, lentiform nucleus, which is again formed by globus pallidus and putamen. Okay. Functions: corpus striatum controls extrapyramidal system, amygdaloid body part of limbic system, and claustrum is not function not known. Now we will discuss the corpus striatum in details. Corpus striatum is located lateral and anterior to the thalamus. কি কথা বলছিস তখন থেকে? চুপচাপে দিয়ে ঘুরে বস. What are the divisions? Corpus striatum is subdivided by the fibers of internal capsule into caudate nucleus and lentiform nucleus. And lentiform nucleus is further divided into globus pallidus and putamen. Okay, so now we will discuss caudate nucleus and lentiform nucleus, their functions. Caudate nucleus is C-shaped mass of grey matter. It has three parts: head, body and tail. Lentiform nucleus is lens. Lentiform is coming from the word lens. Lens is a biconvex mass. So it is also a biconvex lens-shaped mass of grey matter. Okay. And what are the parts? Putamen and globus pallidus. Putamen is large and lateral part and globus pallidus is small medial part. An external medullary lamina separates these two. Putamen and globus pallidus separated by this streak of white matter that is known as external medullary lamina. Okay, and also there is internal medullary lamina which separates two parts of the globus pallidus. Okay, understood. Next is functions: refinement of reflex and voluntary, skilled and manipulative movements, controls the automatic associated movements, prevents unwanted movements and maintains the muscle tone, controls emotional expression of the movement. So these are the functions of the corpus striatum. Now, antero-inferior end of the caudate nucleus and the lentiform nucleus, they are connected by the bands of grey matter passing through the internal capsule, and these bands impart the striated appearance. Hence, the name is given corpus striatum. See here, this L-shaped structure is the internal capsule. Okay. Medial to the internal capsule lies anteriorly there is caudate nucleus. Posteriorly there is thalamus and laterally lateral to the internal capsule here lies the lentiform nucleus which consists of outer part laterally putamen and medially globus pallidus, and this green line they are representing the white matter line. This outer one is the lateral medullary lamina and here is the medial medullary lamina. Also known as lateral is the external medullary lamina, medial is the internal medullary lamina. So external medullary lamina or lateral medullary lamina separating the globus pallidus from the putamen, and this medial or internal medullary lamina separating the two parts of the globus pallidus. Okay. Outside it, this area, this white matter area is known as the external capsule. Outside it, this saucer shaped grey matter structure, this is known as claustrum. Outside the claustrum will be the extreme capsule, okay, and outside it will be the insular cortex. Okay, understood? This is the location of different parts. And here you can see this, and this is head of caudate nucleus. It is C-shaped structure. It is covering over the thalamus, and tail is located posteriorly here. Here is the tail of the section of tail of the caudate nucleus. And see here, this anteroinferior end of the caudate nucleus and the lentiform nucleus, these two are mainly the putamen connected via this structure and forming striations, striated appearance, hence known as corpus striatum. This is caudate nucleus, lentiform nucleus together forming the corpus striatum. Okay, understood? Now phylogeny of the corpus striatum. Neostriatum is recently evolved part and it includes the caudate nucleus and putamen. Caudate nucleus and putamen is included in the neostriatum. And paleostriatum is ancient part and it consists of the globus pallidus. Here is the globus pallidus forming paleostriatum. Okay. In cerebellum also you have read archicerebellum, paleocerebellum, neocerebellum, like this. Neo means newest one. Okay. Paleo and archi, these are ancient one. So caudate nucleus, it is smaller anterior part of the corpus striatum. It lies medial to the internal capsule. It is C-shaped mass of grey matter and it consists of head, body and tail. Head is large rounded projection. It forms the floor of the anterior horn of lateral ventricle. Body is narrow long part. It forms the floor of the body of lateral ventricle. Next is tail. It is slender part and that forms the roof of the inferior horn of lateral ventricle. Anteriorly, it is continuous with the amygdaloid body. Okay. Next, we go to the lentiform nucleus. It is a biconvex lens-shaped mass of grey matter, hence the name lentiform nucleus. What is location? It is located deep to the insula and lateral to the internal capsule. Location of the lentiform nucleus. What are the parts? It is divided by a layer of white matter called the external or lateral medullary lamina into two parts, putamen and globus pallidus. Putamen is large lateral part, darker in color. Globus pallidus is a smaller medial part. It is pale in color due to presence of myelinated fibers. Pallid means pale, pale in color. Globus pallidus is divided by internal or medial medullary lamina of white matter into inner and outer parts. Okay, you have seen all these structures in the previous picture. Now we go to functions. Functions of corpus striatum. Corpus striatum performs important role in extrapyramidal system. It performs these following functions: refinement of reflex and voluntary movements, refinement of skill and manipulative movements of the body, for example, threading a needle, controls the automatic associated movements such as swinging of arms during walking, prevents the unwanted movements, maintains the muscle tone and controls the emotional expression of the movement. So all these are functions of the corpus striatum. Okay. In your viscera table, Viva, you have to know the parts and the functions. Functions are very, very important. See here, this is a coronal section through the lateral ventricle and third ventricle. These are the cavities of two lateral ventricle. Here is the third ventricle. On the two sides of the third ventricle, here are the thalamus. Okay, and this eight-shaped structure is the internal capsule. Here you can see the head of the caudate nucleus. Here is the tail of the caudate nucleus. Okay, here is internal capsule. So medial to the internal capsule lies caudate nucleus anteriorly, thalamus posteriorly. Okay, lateral to the internal capsule lies this lentiform nucleus. Okay, lentiform nucleus again consists of putamen laterally and globus pallidus medially. Okay, and globus pallidus is again divided by internal medullary lamina into outer and inner part. This is external medullary lamina, here is internal medullary lamina. Okay, lateral to the putamen, here is the external capsule. Lateral to it, this grey matter structure is the claustrum. Okay, location of claustrum. And lateral to the claustrum, here is the extreme capsule. Okay, and outside it lies this insula. Okay, insular cortex of the brain. And here below the thalamus, here you can see the subthalamus, and here is the midbrain, the tectum portion. Okay, so these are the structures you have to see. So these red colored structures all are forming part of the uh, corpus stratum. Putum and globus pallidus together forming lentiform nucleus. These are the two medullary lamina, caudate nucleus, claustrum. All these are together forming the corpus stratum. So you have seen the location of different structures. See here, this is lentiform nucleus, lens-shaped biconvex lens-shaped, and here is the caudate nucleus, the green one. Here is head of caudate nucleus, body of caudate nucleus. Here is the tail of caudate nucleus. In this part, it is lying in the floor of the anterior horn and body of the lateral ventricle, and the blue lining is of lateral ventricle. Anterior horn, body, posterior horn, inferior horn. And you can see the tail of the caudate nucleus is forming roof of the inferior horn. Okay, and tail at the extreme end of the tail, amygdaloid body is attached, which is taking part in limbic system. Okay, and this is internal capsule fibers. They are extending upward into the cerebrum as the corona radiata. Okay, forming the corona radiata, and the blue one, blue structure around which the caudate nucleus is lying. This structure is the thalamus. Okay, you have seen in the sagittal section of the brain, thalamus and caudate nucleus. So what are the connection of corpus stratum? These comes in your theory paper. Okay, connections. So neostratum consists of caudate nucleus and putamen. It has afferent fibers. Afferent fibers are corticostriate fibers from cerebral cortex, thalamostriate fibers, nigrostriate fibers from substantia nigra. And efferent fibers are going to striatopallidal fibers to the global pallidus, and few fibers to the thalamus and substantia nigra. Okay. Next, paliostriatum, which is consists of globus pallidus. Afferents are coming, most of the fibers from neostratum, that is caudate nucleus and putamen. Here you can see efferent from neostratum is going to the globus pallidus. So it is globus pallidus, paliostratum getting its most of the afferent from neostratum, and few fibers from substantia nigra, thalamus and subthalamus. Okay, so near from the nearby structures mainly. And efferent fibers is going to thalamus, hypothalamus, subthalamus, red nucleus, olivary nucleus, substantia nigra, reticular nuclei. Through this, ansa lenticularis, fascicularis, lenticularis, and subthalamic fasciculus. Okay, so these are the efferents of the paliostratum. See here, this is putamen and globus pallidus. From the putamen, efferent is going to this globus pallidus. Okay, afferent is coming from cerebral cortex, caudate nucleus, thalamus, substantia nigra, like this. Okay, and this is globus pallidus. You can see the efferents are going to subthalamic nucleus to the thalamus. Okay, from the thalamus to the cerebral cortex, going to red nucleus, reticular formation, substantia nigra, like this. Okay, so these are the afferent and efferent connections. Also to the inferior olivary nucleus. Okay, so these are the afferent and efferent connections of corpus striatum. Now we go to claustrum, next part of the basal ganglia. Claustrum is a thin sheet of grey matter which lies deep to the insula. It is considered as a detached part of insula. Shape is saucer shaped. Okay. Relations: medially there is external capsule separates claustrum from putamen. Laterally, extreme capsule separates the claustrum from the insular cortex, and its connection and functions are not known. Next we go to amygdaloid body. It is a small almond-shaped mass of grey matter in the temporal lobe. Okay. Location: it lies antero-superior to the tip of inferior horn of lateral ventricle, and it lies deep to the uncus. So this is the location. Antero-inferior to the tip of inferior horn. You have seen in previous picture. Antero-inferior to the tip of the inferior horn. Here is the location of amygdaloid body. What are the connections? Afferent: it is getting afferent from olfactory tract. Uncus is here. In the uncus, olfactory cortex is located, area 28. Okay, so it is nearby to amygdaloid body. It's getting efferent from olfactory tract. Efferent fibers form the stria terminalis. Stria terminalis located in the floor of the lateral ventricle. So the efferent from amygdaloid body are forming the stria terminalis, which terminate in anterior commissure, anterior perforated substance, and hypothalamic nucleus. So what are the function? It forms part of limbic system, helps in emotional control. Okay, understood? So amygdaloid body, location: small almond-shaped mass of grey matter in the temporal lobe, lies antero-superior to the tip of inferior horn of lateral ventricle, lies deep to the uncus. What are the connections? Afferent fibers are coming from olfactory tract. Efferent from the stria terminalis, terminates in anterior commissure, anterior perforated substance, and hypothalamic nucleus. Functions: it forms part of limbic system and helps in emotional control. Okay, understood? Next, the fasciculus, through which the lentiform nucleus is connected to other structures. Lenticular fasciculus or fasciculus lenticularis, it carries efferent fiber from the globus pallidus and it passes through the posterior limb of internal capsule. They pass superior to the subthalamic nucleus as the lentiform fasciculus and terminates in the thalamus. Ansa lenticularis, some efferent fibers from globus pallidus curve around the inferior aspect of posterior limb of internal capsule and form a loop called ansa lenticularis, and its fibers terminate in thalamus, substantia nigra, red nucleus, reticular nuclei, and inferior olivary nucleus. Next is thalamic fasciculus. It is formed by lenticular fasciculus and thalamic fibers of ansa lenticularis, so previous two. And subthalamic fasciculus, these are fibers connecting the globus pallidus and subthalamic nuclei, median and lateral geniculate bodies. These are known as subthalamic nuclei. Okay. Next we go to the clinical aspect of the corpus striatum. Important clinical aspect is Parkinsonism. Parkinsonism is a broader term that includes a combination of a group of symptoms such as bradykinesia, stiffness, and tremors. What are the causes of Parkinsonism? Parkinson's disease due to lesion of basal ganglia, side effects of some drugs, infection, and vascular diseases. So these are the main important causes of Parkinsonism. So Parkinson's disease or paralysis agitans, it is a neurodegenerative disorder due to deficiency of dopamine in the corpus striatum. Okay, incidence is 1% individual over the age of 50 years. What is the anatomical basis? Melanin containing neurons of the substantia nigra produces dopamine and which is carried to the corpus striatum by the nigrostriate fibers. Dopamine inhabits neuron of the corpus striatum and lesions of substantia nigra on nigrostriatal fiber. There will be lack of dopamine in corpus striatum, loss of inhibition of neuron of corpus striatum, extrapyramidal symptoms of the Parkinson's disease. Okay, what these are the symptoms? There will be dementia, mask-like face, expressionless face, stooped posture, reduced arm swing during walking, leg pipe rigidity, resting tremor. Resting tremor occurs in Parkinsonism and intention tremor is occurring in cerebellar lesions. Yesterday you have read. Next is pin rolling tremor of the hands, steep shuffling gait. Okay, waddling gait occurring in the cerebellar lesions. So this you have to remember. These symptoms are also important for your MCQs. I mean MCQs they are asked very frequently. So signs and symptoms are resting tremor such as shaking of hands or head at rest, cogwheel or leg pipe muscular rigidity due to increased muscle tone on passive movements. Resistance increases and decreases alternatively, cogwheel and leg pipe. So masked face appearance or loss of facial expression, bradykinesia, that is difficulty in taking initial steps during walking and in terminating the ongoing movement. Pin rolling movements of hand, that is circular movements of opposed thumb over the other fingers, pin rolling movement. Stooped posture, flexed back and adapted and flexed and bent knees. Absence of association movements such as arm swinging during the walking. So these are the symptoms. It comes as a long question in physiology also. Na? Physiology to पढ़े तो Parkinsonism. Okay, so also important in anatomy can also come. So treatment, what is the treatment? Levodopa, dopamine precursor is useful here. Dopamine cannot cross the blood-brain barrier. Hence, levodopa should be given. Levodopa can cross the blood-brain barrier and via enzyme action it will be converted into dopamine there. Small surgical resection of globus pallidus and anterior nucleus of thalamus. This can also be done as a treatment. Okay. So Parkinsonism definition group of symptoms including these three mainly: bradykinesia, stiffness or tremor. Cause is lesion of basal ganglia, deficiency of dopamine, lack of inhibition of corpus striatum leading to extrapyramidal symptoms. Signs and symptoms are resting tremor, cogwheel rigidity, mask-like face, bradykinesia, pin rolling movements, stoop posture. Treatment is levodopa and surgical resection of globus pallidus, anterior nucleus of thalamus. Next, other clinical aspect of this basal nuclei. Disorders of basal nuclei produce Parkinson's disease, we have already discussed. Others are the chorea, athetosis, hemiplegismus. Okay, chorea is characterized by brisk, jerky, and purposeless movement. For example, twitching of face. There are two types of chorea: Sydenham's chorea and Huntington's chorea. Sydenham scoria is a complication of rheumatic fever and recovery is complete. And Huntington scoria, it is a কি কথা বলছিস রে এতক্ষণ থেকে চুপ করে বস Huntington scoria, it is a rare dominant genetic hereditary disorder worsening with the age. Next is athetosis, which is characterized by slow sinus worm-like breathing movements, and it is commonly occurs in fingers and toes. Okay. Next is balismus. The lesion of subthalamic nuclei produces balismus. It is characterized by violent involuntary movement of trunk, girdle and proximal part of the limbs. Unilateral lesion affects the contralateral side of the body, hence called hemibalismus. Okay. Choreos is dance, hemi means half, balismus is jumping about. In these words are coming from Greek. Okay. That's why it is known as mainly hemibalismus. Okay. Next is Wilson's disease. It is seen in young adults following the hepatolenticular degeneration. It is a genetic disorder of copper metabolism. The degeneration of lenticular nucleus and liver cirrhosis occurs in Wilson's disease and it produces muscular rigidity, impaired voluntary movement, uncontrolled laughing or crying. This occurs in Wilson's disease. It has asterixis or wing beating tremor following the extension of the upper limb. Okay. Next we go to the internal capsule. Another very important topic. Internal capsule you must have to know before going to give theory paper. Okay. Internal capsule is a compact bundle of projection fibers. What is the location? It lies between the thalamus and caudate nucleus medially and lentiform nucleus laterally. You have seen in the picture. Next is continuation. Corona radiata and crus cerebri. Corona radiata, the fibers of internal capsule fan out cranially and form the corona radiata, radiating fibers like sun rays. Next is crus cerebri, the fiber of internal capsule approximates inferiorly to form crus cerebri of the midbrain. Okay, so superiorly it is radiating upward to the cerebral cortex as the corona radiata, and inferiorly they are approximated to form the crus cerebri. Okay, understood? Next is shape. It is a V-shaped structure in the transverse section with concavity is directed laterally. Now, what are the parts of the internal capsule? Internal capsule consists of these 5 parts: anterior limb, posterior limb, genu, retrolentiform part, sublentiform part. Anterior limb, it lies between caudate nucleus and the anterior part of the lentiform nucleus. Posterior limb lies between thalamus and the posterior part of lentiform nucleus. Next is genu. It is a bend between the anterior and posterior limbs. Next is retrolentiform part, lies posteriorly behind the lentiform nucleus, and sublentiform part lies below the lentiform nucleus at the posterior end of the internal capsule. Okay, so these are the 5 parts of the internal capsule. See here, this is the location of the internal capsule: anterior limb, genu, posterior limb. So medial to it lies this corpus callosum, this is caudate nucleus, and the thalamus lies medial to the internal capsule, and lateral to the internal capsule lies this lentiform nucleus. Okay, understood? So this is the location of internal capsule. This is the previous one was coronal section. Okay, and see here, these are the fibers of internal capsule. They are radiating upward towards the cerebral cortex as the corona radiata fibers, and below they are approximated to form the crus cerebri of the midbrain. Okay, see this diagram you have to practice. Okay, This is a schematic diagram of internal capsule. See the 5 parts. Anterior limb, vent is the genu. This is posterior limb, and here lies the retrolentiform part, and below it lies this sublentiform part. Okay, so these are the 5 parts of the internal capsule, and here also you can see medial to the internal capsule lies this caudate nucleus and thalamus. Lateral to it lies this lentiform nucleus. Okay, and you can see here the sublentiform part is connected with the medial geniculate body, which is a component of auditory pathway, and this retrolentiform part is connected with lateral geniculate body, which is a part of the optic pathway. Okay, so this diagram you must practice. So internal capsules are projection fibers, continuation upward as corona radiata, below as crus cerebri. These are the parts. It is V-shaped. It has anterior limb, genu, posterior limb, retrolentiform part, sublentiform part. Now the constituent fibers, there are motor fibers and sensory fibers. Motor fibers are corticopontine fibers. Corticopontine means it will come from all the lobes of the cerebral cortex. So these are frontopontine, paritopontine, temporopontine, occipitopontine fibers. Pyramidal fibers, these are corticonuclear and corticospinal fibers. And another is extrapyramidal fibers. Next, sensory fibers are anterior thalamic radiation, superior thalamic radiation, inferior thalamic radiation, and posterior thalamic radiation. Next, the blood supply. Blood supply of internal capsule is also very important. We will discuss in details. Okay. So it is medial and lateral branches of middle cerebral artery, side branches of anterior cerebral artery, cortical branches of anterior choroidal artery, few direct branches from internal carotid artery, central branches of posterior communicating artery, posterolateral central branches of posterior cerebral artery. So these are the blood supply of the internal capsule. Now these are the clinical aspect. These are regarding this blood supply. Okay. Lesion of artery of cerebral hemorrhage. These are also important for MCQ. This comes in your MCQ. Which artery is involved, which fiber will be damaged, paralysis occurs in which area, this will be asked. Okay. So lesion of artery of cerebral hemorrhage is Charcot's artery. Charcot's artery of cerebral hemorrhage. Damage to the posterior limb, it will lead to paralysis of opposite half of body and face. Lesions of recurrent artery of Hubner, it leads to damage to the genu and anterior limb of internal capsule and leads to paralysis of face and upper limb on the opposite side. Okay. Next is thrombosis of anterior choroidal artery. It leads to damage to posterior limb, sublentiform and retrolentiform part. Damaging, there will be visual and auditory defects. Okay, visual defect is leading to hemiplegia. So these are the motor fibers, constituent fibers of the internal capsule. Motor fibers are corticopontine fibers, pyramidal fibers, extrapyramidal fibers. Corticopontine are again from all these lobes: frontopontine, paritopontine, occipitopontine, temporopontine, coming from respective lobe to the pontine nuclei. Pyramidal fibers, these are corticonuclear fibers from the cerebral cortex to the contralateral motor nuclei of the 3rd, 4th, 5th and 12th cranial nerve, and corticospinal fibers from the cerebral cortex to the contralateral anterior horn cells of the spinal cord. Next is extrapyramidal fibers from the cerebral cortex to the subcortical nucleus, such as red nucleus, substantia nigra, reticular nuclei, olivary nuclei, and so on. Okay, so these are the motor fibers of internal capsule. See here the motor disposition of fibers passing through the internal capsule has been shown. Here are the location of frontopontine fiber. This is sensory anterior thalamic radiation. Here is corticonuclear fiber for head and neck are located in this genu. Okay. Anterior limb has frontopontine fiber and anterior thalamic radiation. Here is the fibers for upper limb, trunk and lower limb, corticospinal fibers. Okay. And this is auditory radiation. Here is the optic radiation. Okay, coming from medial geniculate body and lateral geniculate body. And here lies the paritopontine and occipitopontine fibers in the posterior limb. Okay. And auditory radiation, temporopontine fibers are located in this sublentiform part. See here, this chart is very important. This chart you have to know. Okay. Constituent fibers of internal capsule, different parts, motor, each part which motor fibers are present, which sensory fibers are present. This comes in your theory paper. Okay. And arterial supply you have to know for the clinical aspects. So anterior limb motor fibers are frontopontine fibers we have seen in previous picture, and sensory fibers are anterior thalamic radiation. It is supplied by direct branch from anterior cerebral artery and recurrent branch of anterior cerebral artery. Then genu have frontopontine fiber and corticonuclear fibers. Sensory fibers are anterior part of superior thalamic radiation. And arterial supply direct branch from internal carotid artery and posterior communicating artery. Next we go to posterior limb. Posterior limb has corticospinal fiber, corticopontine fiber and corticorubral fiber. Sensory fibers are superior thalamic radiation. Arterial supply by lateral and medial striate branches of middle cerebral artery and anterior choroidal artery. Sublentiform part, it contains motor fibers, paritopontine and temporopontine. These are located in sublentiform part. Okay, and sensory fibers are inferior thalamic or auditory radiation. These are the sensory. Next, it is supplied by posterior cerebral artery, anterior choroidal artery. Next, we go to retrolentiform part. It contains motor fibers are paritopontine and occipitopontine. Retro means posterior. So, posteriorly like this occipital lobes, occipitopontine. Sub means below. Temporal lobe is lying below in the lower part of the brain. So, it is containing the temporopontine fibers. Like this you can remember. Okay. In the occipital pole, there is the visual cortex. So optic radiation will be lying there. So sensory fibers are posterior thalamic or optic radiation and supplied by posterior cerebral artery. So this chart is you remember very carefully. Okay, next we go to arterial supply. Internal capsule gives passages to large number of fibers through a small zone, hence its vascular lesion affects large area of the body. And the internal capsule is supplied by these following arteries: medial and lateral branch of middle cerebral artery, striate branches of anterior cerebral artery, cortical branches of anterior choroidal artery, few direct branch from internal carotid artery, central branches of posterior communicating artery, and posterolateral central branches of posterior cerebral artery. These are the important arteries, these named arteries. Charcot's artery of cerebral hemorrhage, another is recurrent artery of Hubnerl. So Charcot's artery of cerebral hemorrhage is one of the larger striate branches of the middle cerebral artery. Okay, it is the larger branch and more frequently ruptured. Recurrent artery of Hubner is one of the striate branches of anterior cerebral artery. which is large and takes the recurrent course. That's why the name recurrent artery of Hubner. See, this diagram you have to practice for blood supply of internal capsule. You see, this one is internal carotid artery. Here is a direct branch from internal carotid. From here, the anterior cerebral artery, it is giving the recurrent artery of Hubner. It is supplying the anterior limb from the recurrent branch of anterior cerebral artery, and this branch is direct branch from anterior cerebral artery, supplying anterior limb. Okay, and Genu is supplied by direct branch from internal carotid and also branch of posterior communicating artery. This part is the posterior limb supplied by lateral and medial stride branch. This is lateral medial stride branch and branch from anterior choroidal artery. And this part, sublentiform part, it is supplied by branch from anterior choroidal artery, posterior cerebral artery. Posterior cerebral is branch from basilar artery. You have read during circle of Willis. Okay, and here retrolentiform part, it is supplied by branch of posterior cerebral artery. So this is blood supply or arterial supply of the internal capsule. Okay, so this recurrent artery of Hubner and Charcot's artery of cerebral hemorrhage are important arteries. Charcot's arteries is one of the largest branch of the stride branches. Okay. So lesion of internal capsule, vascular lesion of internal capsule are common. It involves rupture of vessels which results in hemorrhage or occlusion, leading to necrosis. Occurs commonly in medial and lateral branches of middle cerebral artery. Effect lesion of internal capsule which results in upper motor neuron type of paralysis of opposite half of body and face. Specific lesions, lesion of artery of cerebral hemorrhage or Charcot's artery, damage to posterior limb, paralysis of opposite half of body and face, common cause of hemiplegia, stroke. Okay. Lesion of Hubner leads to damage to the genu and anterior limb of internal capsule, leads to paralysis of face and upper limb on the opposite side. Next is thrombosis of anterior choroidal artery. It leads to damage to posterior limb, sublentiform, retrolentiform parts, leading to visual paralysis. Okay, visual and auditory defects. So these are the clinical aspects of blood supply of the internal capsule. Okay, that's all. Any queries regarding basal ganglia and internal capsule? Okay, so now we have to see the structures in the viscera. Okay.